Well, welcome to the show, everyone. And today is our inaugural show for 2019 of Spread Love, Banish Fear, my podcast, where parents are empowered with evidence-based knowledge to allow them to make better decisions about their children's health. And today I have a very, very dear guest and a very special guest is Dr. Lawrence Kotlow. He is an expert in laser dentistry and tethered oral tissue, also known as lip and tongue ties. Let me introduce Dr. Kotlow formally. He has been in private practice for more than the last 4 decades. He observed the specialized needs of children. He is known throughout the country for his innovative techniques and caring manner, and he has lectured for some of the top dental societies and dental companies. Dr. Kotlow has lectured in Australia, Taiwan, Canada, England, France, and throughout the United States, learning pediatric dentistry and lasers and tethered oral tissue. All 3 things that are very near and dear to my heart. He also has written over 35 articles and authored chapters in pediatric dentistry and lasers for 3 laser textbooks. He has his own textbook, well, it's a book, but it's a textbook, about tethered oral tissue. And he's got numerous accomplishments and honors, and I am honored to get the opportunity to speak to him today. Thank you and welcome, Dr. Kotlow.
Thank you, Saadia, for inviting me to speak in your inaugural show. You make me feel really good. You know, my wife tells me she's got to open the doors when I come home from a meeting, so she has to hire a carpenter when everybody says those nice things about me. But, you know, it's an interesting avocation rather than vocation. I think dentistry has become more of a hobby for me. That's why I don't retire. My friends around me are all retiring, but I can't retire. I have too much fun doing what I do. Plus, it's a unique opportunity because the things that I do with parents and babies affect not one person. You know, when we fill a tooth, it affects one person. But when we're working with newborns and infants, we're affecting the entire family dynamic state. You know, it's called a dyad, a mother and a baby, but I think it should be called a triad rather than a dyad, because fathers have been ignored for years. That's my dog in the background. I was afraid he was going to bark. Give me a second here. Okay, and the kids love him. And he's my 3rd dog. He's a Havanese, but he's a guard dog. So I'm downstairs in my operatory, but next to me is my private office, and he's got a door. And he looks out. If he sees anybody coming near the office he doesn't know, go back. So now he's outside. We'll see how he does. Anyway, getting back to what you asked, you know, this all started really when I graduated my dental school and my residency and came back to Albany. I practice in Albany, New York, and I've been here 45 years, as I've said. And I tried to get my patients' tongue released. These are teenagers, older kids, or whatever, and I could never do that. Unfortunately, I wasn't able to get the physicians to put them in the operating room and the oral surgeons to do it. So I picked up my textbook and I decided no one was going to do it, I was going to do it. So I went ahead and I started doing tongue ties on the older kids. And as time went on, I used electrosurgery, which was really a burn, and the older kids could handle it and would suture. But it wasn't until I really got involved with lasers, probably 25 years ago, when I found that lasers were more kind to the tissue, less collateral damage. There was no problems. The kids didn't dehydrate. They only did a really good, the post-surgery was much more uneventful and less collateral damage. And I was back in about 1998, I got my first laser. I didn't really like it, didn't do much. And then the year 2000 at the Academy of Pediatric Dentistry, I was asked to lecture on high-tech dentistry. And at that point, it was air abrasion and learning to use PowerPoint and patient communications. And at that meeting, there were a couple of laser companies just introducing the lasers. And people asked me what I thought about using lasers on children. And at that time, I knew nothing, so I thought maybe it might be dangerous. They wouldn't sit there. And I spent the entire weekend at the meeting with the two different laser companies, and finally chose the laser that I felt was the better of the two. And it was in my office in about a week. And my assistant said, air abrasion is put away because it was messy, and we're going to use lasers. My staff jumped right on it. And we started using the lasers for all of our operative and surgery, and found things were healing. And then we started doing younger and younger kids. And then I was invited. I had been doing them, and I had written some articles, but I was invited to a meeting where supposedly it was the top 50 people working on infants, or written about it, or doing research. And there were a lot of people there of different specialties: surgeons, lactation people, chiropractors, other body workers, dentists, pediatric dentists. And I listened to what they were saying, and it didn't teach me how to do it because I knew how, but it validated what I was doing. And then we just started doing more and more of it. And if you're in an area where there's a need and you start to do it, and nobody else is doing it, you're going to get more and more referrals. And I did some lecturing to lactation people here. Unfortunately, the real problem is the medical community fails to recognize it. And on every day in the office, I hear the same sad stories. I mean, I saw a 1-year-old today who only came in because she had a severe lip tie and was having problems with brushing with her teeth. And I looked at the tongue, and it's right to the tip. And the mother said, well, I asked my pediatrician. I went to an ENT, and they told me there was nothing wrong. So she gave up breastfeeding after 30 days. So these are the sad things, because we empower parents to do this. And when my kids were born back in the 70s, only 20% of women in this country breastfed. Okay, now it's close to 80 or 90%. So the fallacy that the medical community uses is that it's a fad. The fact of the matter is we have so many more women breastfeeding, and equally important is that we have women breastfeeding all across the economic spectrum. So back in the 70s, when my kids were being fed, formula was touted in the 50s and the 60s as the best thing. Now we know that that's not true. So, our real problem is educating not the parents, because they get to me through either a lactation consultant or more than often through the internet. And the internet is good and bad. A lot of bad stuff out there, a lot of misinformation. And you know what happens? I can do 1,000 babies, and somebody in someplace else, usually in Australia, has a problem, and they blow it up, and they don't take into account the thousands of babies that we treat successfully. So that's where it all got started. And now, it's important to have your staff on board, because they know what to say, they can calm parents down, and we can make parents feel good. The most important thing to me is, number one, fixing the baby so the mother can nurse, but making sure she understands it's not her fault. The baby's not lazy. She's not doing something wrong because it's a newborn. And I see so many women going into postpartum depression because they don't bond. And if you look up something called attachment theory, that first year, that baby has to bond to the mother, or it can affect the baby and the mother for a lifetime. And then, we were doing this just for breastfeeding. But as you go on further and further and look into it, you find that breastfeeding is just one part of maybe a dozen things. So what happened with me was that it was a Friday, and I had a baby in the office who was what I classified as class 4 to the tip. And the pediatrician said, don't do it, there's nothing wrong. Well, I got so upset. I actually took my 6-hour lecture, told my wife not to bother me for 3 days, and I wrote my book. So it took 6 weeks from writing it to publishing, and having people translate my English into real English. Because to me, English is my second language, because I don't have any other language. But, I talk and I write as I talk. My wife gets upset about that. She said, it's got to be perfect English. So I gave it to somebody to correct. And we're going towards our third remake of the book. We're down, we've probably given out about 7,000 or sold them. Some people do it what I do. We give the book out to every new parent and lactation people and physicians to try to educate them. And the one place we left off is I just came back from Copenhagen, Denmark. And the interesting thing there, it's the same all over the world. They had over 800 pediatricians who didn't want to hear what I had to say. So nobody showed up. We had doctors from Germany and Finland and Switzerland and surrounding countries in Scandinavia. But in Denmark, we have people, lactation people, but no physicians or dentists wanted to hear. They just kind of put blinders on and put their fingers in their ears and go like a kid that, no, I don't want to hear it. And unfortunately, we run into that again with the physicians. And, you know, I used to try to be nice and cover for them, but, you know, I was in the hospital and one of the doctors said, why don't they do it? And I said, I don't know. He said, well, it's willful neglect. They don't want to learn. Okay, so the only way, again, is I work and I lecture, and I teach. You've been to my office. Tomorrow I have 4 pediatric dentists coming, 2 from Florida and 2 from down south, someplace else. I'm not sure. And once a month I teach laser dentistry, not the babies, but to use a laser. And then like this year we'll be in Houston, LA, and San Francisco in the fall, giving the SOS for tax course. But really, when you ask me why I do it, to repeat myself, it's because there's nothing in dentistry that gives me more self-satisfaction than helping not just one person, but a whole family. And that's the key. And that's why I don't retire. It's, you know, I go on the 5-year plan. When I reach a certain age, I'll decide if I'm going to retire. But if I retired, I'd probably be bored out of my mind. And it's not that difficult if you understand and know what you're doing. Like I said, we met. Did we meet at the ALD meeting or at my office? I think you came to my office and we met.
I think the first time I met you, I actually heard you speaking in Palm Springs.
Okay.
With Dr. Margolis. May he rest in peace.
Yes.
And
Fred and I had spoken. But I think when you bought the Saadia laser,
yes.
you came to my office for the course.
Yes.
And then we just met at the ALD meetings constantly. We've connected. And you follow me around every time I lecture, you're there, which is fun.
I'm sitting in the front row until you've said,
That's right.
aren't you sick and tired of hearing me? And I said, no. Every time I learn something new, and I have.
It's like my wife, she comes and listens to me each time, and I say, well, my lectures are dynamic, okay? I do repeat the necessary things, but as I work, I take newer videos, I upgrade the videos, and find other things that are more important. But as I started to say a little while ago, reducing and eliminating these tethered oral tissues is not just for breastfeeding. There are so many babies inappropriately placed on adult anti-acid reflux drugs. They're not recommended by the FDA. They're not recommended by the drug companies. They're not recommended by the GI Pediatric Association. So what happens is these 1, 2, and 3-week-old babies who have reflux come in. What I find upsetting is they don't use the tongue as a differential diagnosis on anything. For these babies who come in, I tell the parents they shouldn't be on it. I'm not a physician, but you make a decision. You want to take them off. But I said, watch, you release the tongue and the lip, the baby nurses, no gas, and I said, feel the belly. It's not distended. The baby doesn't have gas. It's not crying. So, you know, they say that reflux is normal and can last 4 to 18 months. That's not normal for a baby to suffer for 18 months. And when you get the comments that we're hurting the baby or we're doing something when we do the surgery, if you have the right laser, and Saadia is the best one out there, but if you have the right laser, it takes 10 seconds, 20 seconds to do the whole surgery. Babies cry a lot longer than that when they're hungry and when they're wet. And they don't remember. It's not going to last a lifetime. Some of these people out there would say, oh, they can remember when they were circumcised and it's traumatizing. Give me a break. Okay. It's not going to happen when they're newborn. So what happens here is we treat the reflux by releasing the tongue. They get on regular breast milk. The mother doesn't have to have a dairy-free diet. And the number of babies actually allergic to milk or who have true reflux that I've seen are just so few. But sometimes they get to me late, and what are they? They've had x-rays, they've had GI series, they've had general anesthesia. You know, all these things are going to be more damaging than what I'm doing. And if it doesn't work, we can look at other reasons. If it's going to work, when I get the replies back from the parents 3 or 4 weeks later, 94% of the time, everything is working. Keeping in mind, I don't see patients who are more than an hour away, some fly in from all over the world. So it's still a high number considering probably half of the babies I see, I never see. What other questions that I haven't covered in this? I know I can keep going nonstop.
You're just great. You know, I was going to have this as a conversation and ask you questions. You've just answered them all. You're like the super sensei. But you're so right about the GI reflux and everything. You know, I've heard you say that so many times, and now I've actually experienced it. I've had 2 babies that were close to getting GI tubes,
Right.
feeding tubes put in. And after the release and after the necessary therapy, kids are doing wonderful.
Actually, I sent you one, and the mother was thrilled.
Thank you. And these are the stories. I mean, I know when I first heard you say them, I'm like, oh, he's doing all this, he's over here. But then after years of learning and doing it, it's like every baby that we treat, it transforms lives.
Well, equally important is brain development. And a lot of the studies that are going on now show that in the first 90 days, a baby's brain is growing at the rate of 1% per day. And by the age 2, they're over 50% of the adult brain size. So when these babies are tongue-tied, they get sleep apnea, they have reduced oxygen flow. And studies are showing these are the kids down the line that have ADD and ADHD. And I get parents and I come in and I show them this video that was produced by the Academy of Physiologic Breastfeeding in Dentistry. Well, Finding Connor Deegan, and you go on YouTube and find it. Finding Connor Deegan. And it tells the story of a little boy who was misdiagnosed. You know, the tongue was corrected, he had his tonsils and adenoids out, and he went from a difficult, reclusive kid to a A and B student and total behavior change. And I see this with parents, and they come in and they're in tears. And their comment is, well, how can you make a diagnosis like that in 5 minutes? I said, because it's obvious. Your kid's got circle over his eye. He's not breathing correctly. I have a list of 25 different symptoms that we can look at to rule out or determine if a child has any kind of sleep apnea or obstructive sleep disordered breathing. And so again, we're now wearing many different hats. We're dealing with breastfeeding. We're dealing with GI problems. We're dealing with hormonal problems in the mothers. We're dealing with now breathing problems and airway. So it gets wider and wider and wider, the number of things that can be related. Because if you understand that from your head to your feet, your body is encased in fascia. Okay? And if you've got the tongue that's stuck and the head is forward all the time, it can affect all other body areas. That's why when we do this, you know, the ideal conditions, I like the lactation people to see the baby. And even there with the lactation people, the IBCLCs, you know, it's kind of a catch-22. They're not allowed to make a diagnosis. And if you're in the hospital, they're not even allowed to mention tongue ties by the physicians. You got to go to an outside lactation consultant. And a lot of them don't know how to do the exam because the baby's head has to be in your lap. You've got to get your fingers in the mouth. You've got to watch the mother nurse. So you look at symptoms, you look at function, you look at appearance, and then you can go ahead and treat. And they should be able to refer. And many times they don't recognize it and baby gets here without that first step, which I'd like to see. The second step is, you know, when we see a baby, we put him down and some of these babies have been stuck in the birth canal. They come in and they have a torticollis, which nobody's diagnosed. They're shaped like a C. So we use the body workers, such as the chiropractors, the craniosacral and when we work together as a trio, that gets the baby latched on, relaxed, and it changes, again, their lives. So it's a team effort, and that's what we like to do, is work as a group to get the babies and the parents, mothers and fathers, all on board and save lives. Give me 1 second, I have to return. I'll be right back. You know, you also bring up a question about apprehension with parents. So
go to that question.
Okay.
I really want to delve into, because being a woman and dealing with breastfeeding moms, especially as a pediatric dentist, not just me, my whole team, at first we were all kind of like, oh, how do we do this? And we kind of got over it, but we're women. So I really want to delve into you being obviously a gentleman, and in this arena of dentistry and pediatric dentistry, which is not something we're trained in school about lip and tongue ties. And we're definitely not taught about breastfeeding. I know I wasn't. How do you, because you are a leading expert in this area, I want to really talk about how do you manage that? Because as women, I know we're all like looking at each other and we're like, oh yeah, at first it was kind of hard. And then after a while, it kind of like becomes, oh, we're nonchalant about it. But how do you deal with it?
Well, if you go back about 40 years, okay, one of the things we haven't mentioned is women who at will breastfeed during the night. Some of these babies get facial decay. And again, people say, oh, it can't happen. Okay, but it does. Okay, if you have an upper lip tie that's significant, milk pools around the teeth, and they get a different type of decay than you see with the bottle. So if I go back about 40 years, a girl I went to high school came into the office one day with her baby, and the baby had beginnings of decay on the 4 front teeth. And she did nothing but breastfeed. She couldn't understand. So I took a look at it, and I had no idea what was going on. So anyway, while we're talking, the baby is nursing. And so, okay, let me take another look. And when I took a look afterwards, and I lifted the lip up, there was milk all over the teeth. So that led me to believe there was something going on. Because, go back a little further, I was treating a lot of Medicaid kids who had milk bottle decay. And whenever we did the milk bottle decay and we could save the teeth, we would crown the teeth and I would cut the lip, because the lip was always pulling the tissue away from the teeth. And I noticed when they were 5 and 6, number one, they didn't have a diastema. The lip healed nicely and they never had any problems. So I said, okay, let's extrapolate that. Why should only the Medicaid patients end up that way? And we started doing more and more lip ties on other kids early. And when we started doing them early, we saw less and less problems, less orthodontic problems, less tooth decay. And that's where I really started doing the lip more and more, and then the babies. But going back to your original question, you know, and early on also I was talking to a mother, and all of a sudden the child, the 3-year-old, lifted her shirt up, put her onto the woman's breast. Didn't know where to look or what to say, because that was the first time that had happened to me. I felt a little uncomfortable. Okay, but that, in combination with what I was doing, made sense. And it never really bothered me after that. You know, if you talk to people outside and they say, you're telling me you see 30 women's breasts a day? Okay, they don't understand. That doesn't mean anything. And you know, I know there are a lot of male pediatrics that won't do it because they're afraid of getting sued or malpractice. But I only think I've had 2 women in the 40 years who didn't want me to watch them nurse. Okay, and that I respect their right to do that. But for the most part, most of the women I see on a scale of 1 to 10 are toe curling 20 in pain, and they don't really care. It's sort of like when you're in the delivery room and all the physicians are there. You want to deliver your baby and get it done and over with. You don't care who's watching. Okay, well, it may, but most people don't care. It's the same thing here. As you start to do it more and more, it's a non-issue. Okay, But when I lectured, it becomes an issue. I lectured at the Academy of Pediatric Dentistry one year. And, you know, when you get the responses back, there were like 450 people. Fred and I had done it together. And there were like 4 comments from 4 different people. One, we were just a couple of guys trying to sell lasers and make money. Another one said that he would have to learn to practice dentistry totally different because we were preaching dentistry on a different level and scale. And another guy said, all you did was show pornographic pictures. And, you know, you just shake your head. We're not taught in dental school. We're not taught in our residencies. And so what happens is you really learn firsthand by yourself. But the fact that I'm a male working on, I mean, it's a non-issue to me. And it's like, I guess, working on kids. There are some general dentists who don't want to look at a kid. They don't even want them walking in their office. Okay. So the only thing that I have seen change when I was in dental school, I think we had 6 women in my dental class. Now I think more than 50% of the pediatric dentists are women. And you see more and more women going into dentistry. Hey, you know, it's a great profession. You can pick your own hours. You can make a good living. And if you enjoy what you do, it's not difficult work in pedo especially. Okay, you know, when you get into oral surgery, fractured jaws and major stuff, you get into involved orthodontics, or you get into other areas, crown and bridge, where you're doing 12-unit bridges or something and implants. That can be a little more stressful. But kids, it's fine. It's changed. I mean, you can't put a kid on your knee and say, okay, honey, we're going to count your teeth. And you don't, you know, you have to make sure you've got 1 or 2 staff with you at all the time because society has changed. But the bottom line is, whether I'm a male or a female, I don't think it has any factor in what I do. For me, I think each person has to look how they want to handle it themselves. But to me, I'm helping the parent. I've walked out of rooms with tears in my eyes when I get the whole story, and when we bring them back, and the mother is, you know, crying because suddenly her baby is attached to her and not hurting her, and this is what she heard. You know, if you read the opening line of my book, for 9 long months you've been working on developing this baby inside of you, and you've heard all the wonderful stories about breastfeeding and how well you bond, and 5 minutes after the baby's on your breast, it's a toe curling pain and you're in agony as if something's wrong, and all you get told is you're just a new mother, you're just being over anxious, and then you get a grandmother and there's, oh, I breastfed your kids for 3 months and it hurt, it's supposed to hurt. So you're dealing with a whole family dynamics, and in 5 minutes I can change all that. There's nothing else we do in dentistry that's going to do that. It just can't be done.
And thank you for answering that, because I agree it should make a difference to the person practicing, but you have, as a gentleman, a lot of empathy. And to be able to empathize with the mother, because most practitioners do not have that level of empathy to empathize with a woman. And to be able to treat the baby and recognize that it is such an important thing in the mother and the pain that it's causing. That's where, as an observer, as one of your students, as someone who calls you sensei, that's where I give you a ton of kudos. Because I don't see that all the time. It's almost non-existent. Between you and Dr. Margolis, those are the 2 people that I saw that level of empathy and compassion. And that's what I respect and I salute.
I think that when you go into pediatric dentistry, you should have that level because, again, unlike adult dentistry where you come to my office, you sit down in the chair, I've got to explain everything to you. In most cases, you're there. You don't have someone holding your hand or anything. And with kids, you know, you've got apprehensive parents for routine dentistry. And that's why we don't have parents in the operatory. They create more difficulty. I mean, people think the mother and father should be there. I've practiced without it for 45 years, and there are some parents who adamantly won't let me work on their kids. But you know what? I get it done faster and quicker when the child pays attention to me. And we're working with the babies. They're horizontal. My assistant is cradling them in the right position. Okay, if I had to worry, and I've had parents pass out. I had one when I was on call one Saturday. Okay, a 12-year-old knocked out central incisor, totally out. The father brings him in, and again, I will not see a child alone. So he's sitting in my assistant's chair. I said, "Can you handle this?" He said, "I'm a nurse anesthesiologist, no problem." So as I replant the tooth, his eyes turn white, and he's on the floor, cold on a hard floor. His wife comes running in with my kid. Okay, I said, "I get your kid under control, no problem. But your husband is out cold. Take care of him." So now I got two people I have to deal with. So, I remember years ago when you used to have gas stations that worked on cars, because all you had to do was open the hood. It wasn't computerized. You had to change a belt. It wasn't as complicated. But they used to have a sign, $50 an hour or $500 an hour if you watch. And I've thought of putting that up sometimes, okay? And not that I don't want them to see it, because the best PR I could have is parents watching how good and well we do it. But it adds another level of patient management, because even when a 2 or 3-year-old were doing an exam, and I said, "Do you know how many teeth you have?" And the parents said, "Oh, he has 20. I said, "You don't understand. We're trying to create a dialogue. When we're working with the newborns, we want to get in and we want to get out, okay? We want them to cry because we know they're breathing. We don't want them to cry from pain." And it's interesting, a lot of times with the Saadia, when we're doing the surgery, they stop crying. It's before and after, okay? And there's so much controversy about numbing and not numbing. We just don't want any chemicals in this baby. We don't want to have any chance of any kind of reaction. The only thing we do is we use something called sucrose, sugar, and we found a company called Sandbox Medical, and they make these things called Sweetums. It's 28% sucrose, and it comes in a 1 cc plastic vial, and we put that on the tongue and lip before we do it, and then after we do it, probably 90% of the babies we return aren't even crying. And they look at me, "Did you do it?" It's not that traumatic. Okay, so the tears of joy, of fear, become tears of joy. And that's, in my lecture, there's so many things that we pick up, because we're not just what I call a tooth-odontist. Okay? We're medical doctors of the mouth. And we pick up things which are ignored. We had a little boy who was 6 or 7 years old come in recently, and he was missing 9. He came in because he was tongue-tied to the tip of his tongue, and that he was not speaking correctly. So I look at him and I said, "Does he have any genetic problems?" "We don't know. We've been going from doctor to doctor." So I said, "Let me get some x-rays." And he's missing 9 permanent teeth. He has a mid-third hypoplasia, very, very fine hair, pointed teeth, and he's tongue-tied. I said, "Your child has ectodermal dysplasia." She looks at me like, "We've been going to doctors. No one can put a label on it." So, we need to learn that the stuff we learn comes into play every day. We see Down syndrome babies, newborns. They're going to be floppy. Parents have to work on it. It's real important for body work. Okay, we've got kids who come in with other genetic defects. We've got kids who come in preemies. I saw a baby had been in the NICU for 3 weeks, and they had this kid on oxygen because he couldn't breathe. He was in the other day. He had buccal ties, cheeks couldn't even move, lip tie, and his tongue was right to the tip. If they just allow or just acknowledge the tongue needs to be part of a differential diagnosis, there's so much less money the insurance companies would have to put out. There's so much less pain and discomfort the parents have to go through, both physical and mental. And again, one of the things which disturbs me more than anything are these women who come in postpartum depression because they haven't bonded. And that's an important aspect of what we do. So again, going back to what I said, we're a psychologist, we're a GI doctor, we're a pediatrician, we're a dentist, we're an oral surgeon, and go on and on and on. But the physician, blinders. ENT, blinders. GI, blinders. And they don't even want to listen because they're stuck behind this wall called evidence-based dentistry and medicine. I call it evidence-biased because they don't look outside the box. Now, good example is the dean of the dental school at Buffalo wrote an article many years ago, defined something as scientific plausibility. That means you don't need to do a randomized control study. The evidence is so overwhelming of what you're doing that it's your skill and your clinical knowledge that overrides that. So what he did is he said, okay, and I think you've heard me give this example. I have 12 people in a room, and I've developed a new device called a parachute. On each one of you, you have a backpack and a pull cord, but only 6 of you have my parachute. And we're going to go up in an airplane today, and I want to do 2 things. My first is to show you that if you jump out of a plane without a parachute, you're going to die. Second thing is gravity is going to pull you down rapidly, where those who have the parachute are going to gently glide down and survive. Now, that's scientific plausibility. Okay. We have so many of us doing the babies correctly and getting the results we're getting. At this point, the evidence out there and the experience shows that not doing it is more in the area of malpractice than doing it. You know, if I could go back and be a lawyer, all these babies are coming in which are being told there's nothing wrong. Just fight through it. You know, that's where the pediatricians and the ENTs find themselves in trouble one of these days, because one parent will be so PO'd that they'll take it to the next level. When it happens, it happens. Next question for you.
What's the most interesting, because you answered a lot of the questions for me. So, but what is the most interesting thing about you that we wouldn't learn from your website or your resume?
You know, as I mentioned earlier, I look at dentistry as an avocation, as a hobby. I still work 5 days a week, 2 half days and 3 full days. On the weekends, I try to play golf. So it's a practice of dentistry. If I play golf like a dentistry, like I do golf, I'd be out of business. So like being the weatherman when you play golf. You get it right one time and wrong the next time. My kids, for the most part, live in town here. I have 6 grandchildren, 3 kids, and their spouses or significant others. And, you know, I don't have to travel all over the country because my kids stay home. They want to be with their parents. We see them all the time. There's really, in my practice, in my family, and in the friends we have, that's my life. And that's why I wouldn't move to Florida and give up what I've got here. My kids might not move to Florida, give up what we got here, snow and cold. And like, it's now sunny outside for the first time in 4 days. We've had nothing but rain for the last year. It seems like we're in Seattle. My golf game is going down the drain to a certain extent, but I don't think there's, you know, lecturing, treating patients. I mean, my staff has been with me for some cases over 40 years. Some are 6 months, but for the most part, my hygienist and assistant have been with me forever. Like I said earlier, most of my dental friends have retired, so I have to find new friends because they either moved out of town or they play golf 7 days a week. But this is fun. It's doing something for society that other people may not do. You know, it's people say, "Oh, I drive a Tesla for the ecology." I said, "No, I drive a Tesla because I like the car." But there's an ecological advantage too. There's really, other than what you see is what you get. Okay? There's no hidden agenda. There's no other things. I mean, I could sit down and write more articles and more books. I just don't have the patience to sit there in front of the desk and write sometimes. I really can't give you anything really, really special. You know, I've been married almost 50 years. I guess that's special in this day and age. But my kids live in town. So between my practice and my family, I have no bucket list. What else can I tell you? Oh, I'd like to get a hole in one.
Well, you know, you were just, thank you so much for taking the time to do this and all the things that you do. You are transforming lives, not just from the surgery, but from all the teaching. You are one of the people that has taught me a lot.
Wait a second. Ben,
So I was just trying to say thank you so much for doing this. And you've just been a force, and you've been a leader and a pioneer, not just in laser dentistry for pediatric dentists. Because when I got into pediatric dentistry and lasers, it was like, oh, lasers are bad. They burn and they do horrible things. And I would look around and be like, who's a pediatric dentist who's doing laser dentistry? And your name would come up. And I knew that someone of your caliber, if you're using lasers, you're doing it with the right way and with the right thing. And you're one of the forces behind Academy of Laser Dentistry also. Not only are you doing all the other things, you're Academy of Laser Dentistry, one of the founding members.
No, I wouldn't go that far. No.
Not one of the founding members?
No, they started in the mid-90s with the real early adapters. Okay, and it wasn't until at 96 there was the first ND Ag, 1996, which I got, and then returned it because it wasn't much better than the electrosurge because it was only 2 watts. But then in 2000 is the first year I went to the Academy of Laser Dentistry, and I just got more and more involved because I'm a techie and I like doing all this stuff. And most of the laser companies I've worked with it to improve it for pediatric dentistry, change handpieces, change tips, change power. And when we got the first they handed it to me. I was the 5th one off the assembly line from this company. They said, we don't have any settings. We don't know what to tell you. And there were 5 of us who got them at this one meeting. And we met 6 months later. We all had the same relative settings within a few degrees of difference. But we were given erbium and said it couldn't be used for soft tissue, only hard tissue. And then I said, well, you're going to have to listen to my lecture because it's 30 minutes of soft tissue surgery. And then they introduced the diodes, which were good because they didn't bleed, but they were slower. And they have CO2s out there, which are soft tissue only. The problem with them is they don't have amine beams. They don't have water to cool the tissue. So I don't think they're as effective as the Saadia, which cuts hard and soft tissue, has water and air and an amine beam, which I think are important. But I don't want to get into a whole lecture on the lasers for you today.
But you've been one of the first pioneers in pediatric dentistry and lasers.
That's true.
Yeah.
The Academy of Pediatric Dentistry pretty much ignored lasers. And that's why the Academy of Laser Dentistry, Fred and I started the course there, and we started getting the pediatric dentistry to come to the Academy of Laser Dentistry. And we still do. I mean, when I give a lecture there, it's usually an overflow crowd because that's where they're going to get the best information, because it's still not something that's taught at the Academy of Academy of Pediatric Dentistry. They don't get the lecturers there, they don't get the speakers, and they don't push it. And even if you go to their guidelines, they're at the end they say, well, more research has to be done. You know, they're kind of too conservative for me. No.
I know what you're saying. Many years ago, I did also present about laser dentistry at the Academy. And it was worse than pulling teeth, trying to think about it. And I can pull teeth all day long.
Yeah, it's very easy to pull teeth.
Right.
17 years.
My own academy, which I love,
yeah,
it was, okay, it was completely foreign.
It still is.
Yeah, it's unfortunate, but hopefully with the Academy of Laser Dentistry and people like yourself, more and more people are adapting lasers.
As the older gentlemen and ladies retire and younger people come into play, maybe they'll be more progressive.
I hope so. I think there is a big need for, I know in my area, laser dentistry and tethered oral tissue is embraced, thankfully.
Good.
Parents do see the viability for it. And we just can't be doing the same thing that we did 40 years ago in pediatric dentistry.
No.
That's what led me on my path, because it's like, these kids are cutting edge. How can we be practicing pediatric dentistry the same way that we did 40 years ago? That just doesn't make sense to me.
I see people who brag they have the same handpieces they had in dental school.
I just don't, like, I don't compute that very well.
They don't want to spend any money and they don't want to learn.
You know, that's the other thing. Lasers, investing in lasers and investing in all that technology that I see behind you and investing the time in it is expensive.
But it gets, the return on your investment is never going to put you out of business.
Yeah. If you're a passionate professional like yourself who's on purpose, absolutely. But you're absolutely right. Not everyone's willing to do that. Most people are just like, okay, we're just going to do it this old-fashioned way. And that's where our academy, unfortunately, has to look at things different. There has to be a shift in paradigm.
Well, we can have a whole hour discussion on that.
I know. I could get you all started on that one.
I'll get you started there.
Well, I'm going to thank you so much for this.
Okay.
And we're going to put this out there, and hopefully we'll get people to make the changes that are necessary. So,
Real good comment. Thank you.